here in a few minutes, but I wanted to turn the mic over to you so that you can kind of introduce what it's going to look like after today.
Okay.
If that's okay.
Yeah, so what we're hoping to do is do an hour-long training, but the first part of the training, 30 to 40 minutes, is going to be a lecture, and then the second part is going to be question, answer, and discussion. And if what we're hoping for is if people want to bring a case, that you bring a case with you to the session to talk about it. And hopefully we're going to set it up so that anyone who wants to bring a case can talk to me beforehand so we can prep a little bit, but also should be really casual about it. So not to make it a daunting process, because we just really want to learn from each other. And it'll make the ECHO webinar a lot more just vibrant if we can do that.
Awesome. Awesome. So if there, I will try to get through the content today relatively quickly so that there will be some time at the end for questions. But as always, if you guys have any questions or thoughts while I'm speaking, feel free to just interrupt me or shoot a chat, and we'll pause and try to attend to that question. Same thing if you have anything that you want to add while I'm going through.
Sure.
Feel free to jump in. So let me just share my screen so we can get this up. I just hit share screen, right? All right. Like riding a bike. Just get back on it. I'm going to open this slideshow. And can I minimize this?
You can.
All right. Okay. So we're going to talk about risk assessment and safety planning. This lecture was prepared for independently licensed counselors or social workers who it is within their scope to do risk assessment and safety planning, certified peer support workers that I would encourage you to think about as we're going through this information. Not so much that you would be tasked to provide this service, but just so that you can be aware of what this even means, what some of the risk factors and warning signs might be, and so that can be in the back of your mind, because you are on the front line and you are a really valuable member of a behavioral health team. And so if you're sitting with somebody and you recognize some of these warning signs, to be able to get the patient to a licensed provider to do an actual risk assessment is a really vital role that you play. So I'm glad that you're here today, because I hope that this will enrich sort of your perspective when you're sitting with folks. And for the our counselor who's in the audience, hopefully this will just enrich what you're already doing in terms of your risk assessment and safety planning practice. So I like to start this conversation by going through a couple myths and facts, and when this is a live lecture, I ask you guys to jump in, but because of the delay, I think this will slow us down. So I'm just going to introduce this, and in your mind or in your office be guessing while we go along. Is this a myth or a fact? More people commit suicide in the winter months. This actually is a myth. We tend to think, yeah, people get more depressed around the holidays, there's seasonal affective disorder, but actually the highest suicide rates occur in the spring. And one of the reasons why we believe that is because people start to come out of that deeper depression that tends to be an onset during the winter months. And when there's more sunshine, they can get more activated, which means they have more energy to act on the suicidal ideation that's been there all along. So they've been suicidal in terms of their thinking throughout the winter months, and then spring comes along and now I have the energy to actually follow through on my plan. So just thinking about if there's a time of the year that we want to be really careful with folks, when it starts to get sunny and warm, that's when we start to really want to make sure that the people that have some suicidal ideation, we're talking to them pretty frequently. Next question, teenagers are the highest risk population. Well, that's also a myth. Actually, we know that the people that are most at risk in terms of completed suicides are white men over the age of 85. They are by far our highest risk population, so our white senior citizens, and followed by white men over the age of 65. So from 65 and above, that's our highest risk factor compared to the general population. Having a close family member complete suicide increases risk. Is that a myth or a fact? That's definitely a fact. And this is an important thing to kind of keep in the back of your head when you're talking with people who have some suicidal ideation. Just close this. Okay. Won't let me. Having some suicidal ideation going on, and they're saying, I feel like a burden, and I don't see any point. My family would be better off. Letting them know this particular statistic that that if they really care about their loved ones, particularly their children, completing suicide is going to put those family members at very high risk to to act on suicidal thinking themselves. So kind of having that fact in your mind can be a helpful clinical intervention, letting people know if you decide to go along with that plan, you're going to actually place the people in your life at significantly higher risk to follow you. Okay. Talking about suicide increases a person's likelihood of acting on it. This is a very common myth that we hear all the time, and there's no association whatsoever between talking about it and acting on it. There is, however, a strong correlation between failure to ask about suicide and completed suicides. So in fact, where we go wrong is when we don't ask about it, when we are afraid to talk about it, or we're uncomfortable talking about it. Children are not at risk for suicide. This is another myth, that approximately 56 children under the age of 12 commit suicide annually. So for those of you that might work with kids or even have kids in your life, keeping in mind that this does happen. It's less frequent, but it does happen. So we want to be thinking about what are those warning signs, what are those risk factors for everybody. Some more, suicide is was the second leading cause of death for 15 to 24-year-olds in 2015. This is true. Is this surprising? Well, if we think about this demographic, not necessarily the case. Our brains aren't really fully developed until we're about 25 years of age, so that means that our ability to think into the future, to make good plans and good choices for ourselves is sort of impaired. The likelihood of abusing drugs and alcohol is much higher in this demographic. Being emotionally dysregulated is much higher in this demographic. So our teenagers and our young adults are a risky group of folks that we want to be absolutely assessing for suicide risk on a very frequent nature. The 2015 Youth Risk and Behavior Survey found that in that past year, high schools, when they asked high school students, about 17% reported that they were seriously considering suicide. About 15% had actually made a plan. About 8% had attempted one or more times in that past year. And 3 had made a serious attempt where they had to go to the hospital. So that's 3% of the high school population that was surveyed. So that says that a fairly large group of our adolescents, this is a problem that's happening for them. Whites are the highest risk racial group. Well, this is sort of a true answer, right? That the only group that is at higher risk is Native American, American Indian, Alaskan natives, followed by white or Caucasian. So those two groups we want to consider. Men are more likely, we already talked about that. Women are more likely to attempt, and men are more likely to die by about 3.5% to 4% more likelihood. And one of the reasons why is because the means that men tend to choose are pretty final. We have more gun deaths or jumping and hanging deaths completed by men, and women tend to choose things like overdose, where there is an opportunity for them to be rescued and resuscitated. And substance use is the most associated condition. This is a myth. The number one condition that is associated with suicide is depression, major depression, persistent depressive disorder. These depressive conditions are the most likely, followed by substance use disorders. So if we see that on our patient's file, we want to always be thinking, I need to regularly be assessing for suicide risk. And treatment decreases risk, absolutely. And that's one of the reasons why you guys have logged in today to learn about this important topic, because you have a vital role to play in helping keep people alive. We know that if we help treat the mental health conditions that are affecting a person and leading to the likelihood that they will act on suicidal thinking, that we're going to really dramatically impact that risk and be able to bring it down. So the more we can help folks, the less likely we're going to see suicidal outcomes. So some facts about suicide to keep in the back of your head. This is the 10th leading cause of death in the US, and it tends to be creeping up every couple of years. So in fact, I think this data was from 2015. If I recall, I need to update my slides, but if I recall the data that came out from recent CDC, it had bumped up to the 9th leading cause. So we're just continuing to see higher and higher numbers. On average, about 42,000 people will die per year because of suicide. So that means that one person commits suicide about every 16 minutes, if we think about that. And when we talked about that 11 times higher risk for family members, keeping in mind also that when someone commits suicide, it affects at least 6 other people in their world, friends, family, coworkers. This is a different kind of death, and it has some really profound ripple effects in the social circle of the individual. The other important variable that I'm going to beat into your heads in this lecture is the importance of assessing for firearms. Firearms account for 50% of all completed suicides. So if we're talking about depression, if we're talking about suicidal ideation, personally, I think if we're talking about a general assessment with anybody, we want to ask, do they own guns? If they do, where do they live, and who has access to them? That is a really important variable for for clinicians to be aware of. And also considering that for every completed suicide, there are approximately 25 attempts. What does that mean? That means that there's a lot of opportunity in which we can intervene. If we're asking the right questions and we're asking those questions regularly, there's going to be opportunity for us to prevent that person from dying. This is some more data for you to take a look at and kind of look at the highlighted pieces in orange. Some of the statistics of things that are going to line up with the risk factors we're going to talk about here in a minute. That for those who have had a severe attempt, meaning they had to go to the hospital or be resuscitated because of their suicide attempt, we see that the types of symptoms that they're reporting, lots of severe anxiety, insomnia, not sleeping is a huge risk factor. So when someone's coming in and saying, I'm sleeping really poorly, I'm getting 2 to 3 hours of sleep a night, or I'm only sleeping every few days, we want to really start to assess for suicidal thinking. 80% depression, 78% conflicts with relationships. The other thing that I think is interesting to think about is, 84% are saying they had no plan, that this was an impulsive attempt. And in parallel to that, 83% had seen somebody that month. So again, are we really assessing as frequently as we should be? Are we asking those questions on a regular enough basis to be catching this stuff? So just some information to kind of keep in the back of your head. Now, in terms of what causes somebody to become suicidal or have suicidal thinking, there's a couple different theories. One is that this is a coping style, particularly for the patients that we tend to work with that have a lot of severe mental health issues and substance use issues. Suicidal thinking and even suicidal behavior can develop as a response to the stressors that are going on in their life. So essentially how some of us might be thinking when life gets really difficult and we lean on our healthy supports, or we go to the gym, or we do some mindfulness meditation. We have different ways of coping with those stressors. For individuals who may not have that skill set, suicide becomes one of the ways that they cope, or at least thinking about it becomes one of the ways that they cope. So if you can normalize that in your mind, it kind of makes sense. If I'm in a tremendous amount of pain and I don't see an end to that pain, and I don't know how to fix this problem or make it any better, and I feel kind of hopeless that it is ever going to get any better, then dying, it seems like a solution. It seems like a reasonable, rational solution in that moment. So our work is to help provide a space for them to be able to talk about it from that normative stance, and also to be able to give them alternatives to that. How do I help you take dying off the table by giving you other options, things that you can do instead? So thinking about it as this is actually an understandable coping style to manage stress. The other reason that people will commit suicide is that it's impulsive in the moment, right? And so we saw that 84% that had no plan prior to acting on it. So this becomes, again, a way of having poor problem solving, not being able to see into the future, and 9 times out of 10 being intoxicated at the time that they're feeling all of that emotional distress, and they act in the moment impulsively, or act in the moment as a reaction to some sort of interpersonal fight or discord, right? So keeping in mind that we want to actively be talking to people, even if they're telling us I'm not suicidal. If you know that they have a lot of those risk factors, helping them to have skills to use in those moments where they're likely to act impulsively. And then a smaller subset of folks we know will have a long-term plan, and that their suicidal attempt is premeditated. This is a smaller group of people, so this is where we start to see they're giving away things, that they might even see an improvement in mood right before they act on it. So that's why we want to be balancing when we're talking about other warning signs. It's not just people doing really poorly and feeling miserable. When we start to see a major change in status, we want to be re-asking, because it could be that there's some premeditation. So it is a multifactorial event. It is a combination of all of these different variables: how the person is wired, their personality traits, is substance use on board, is severe mental illness on board, do they have access to lethal means or weapons, what kind of life stressors there are, how vulnerable they are psychologically, is there family history, is there a sense of hopelessness and helplessness, do they have a pattern of impulsivity? So thinking about all of these things is really important, because it's not just one thing that contributes to somebody either thinking about committing suicide or taking action. This theory, called the interpersonal psychological theory, leads us to be able to sort of put weight behind certain factors over others, because it says that we need to have this where people are most at risk, where there's a serious attempt or a completed suicide, is where this overlap between feeling like I am a burden and I do not belong, either to society or my family or my group. So I am alone and isolated and different. I do not belong, and I am a burden to the world or to my loved ones. When that overlaps with having the ability to act, right? That when the lethal means are present and super easy to get to, and that burdensomeness shows up, that's when I'm going to be most at risk. So those 3 factors we want to pay really close attention to. Of all these variables we just discussed, these are the ones that we want to be really, really honed in on, because that's where our highest risk is going to be. So then what is risk assessment? What is the purpose of thinking this way? Well, it is an established clinical judgment that helps us to determine the level of risk and the likelihood of risk in the near future. So we're doing sort of a weighing on a scale of a very large amount of clinical details to make a clinical judgment. There is no one agreed upon tool that I can give you that's going to equal, if they scored a 20 on this scale, that means they're going to commit suicide. It's not that clear. That this really does take a lot of practice and a lot of thought to do well. So when we're talking about risk assessment, we're talking about identifying the modifiable and treatable factors. What can we target for intervention to decrease their risk? And what is not modifiable, or what is ongoing risk that we need to give them enough coping skills to manage. This allows us to take care of our patients and also to take care of ourselves, because suicide is a reality of working within the mental health system. About 15 to 68%, so about 50% of any given mental health provider is going to experience a patient committing suicide at some point, and even 33% of trainees. So for those of you that might have trainees at your setting, we want to make sure that they're fully aware of this as well. And that's why I'm glad that we have some peer support workers here today, because I also think it's important for you to be thinking about this too. How do I align with my team to help identify some of this risk and get the patient to the right person at the right time? Because it's just a reality of working with some really sick folks. So now let's talk about some specific suicidal risk assessment. I'm going to skip the case just for time, and we can come back to it if there's time. So best practice standards of care require that we do this at a minimum at the initial visit and whenever indicated. But you kind of know, once you're more familiar with the risk and the protective factors, how frequently you need to do this, even if you need to do this at every single encounter. Effective assessment is going to have that balance scale of looking at both what are my risk factors and what are my protective factors, because if they balance out, that's going to help me to make a different decision about their level of risk versus if one outweighs the other. So if you think about it, it's not an event, it's a process. And good risk assessment is always going to include understanding who the person is in front of you, knowing that you have a thorough history and that you have some good data to be able to make the best possible clinical judgment that you can. So when is it indicated? These are some things to keep in mind. You always want to do a risk assessment anytime there is an emergency or a crisis evaluation is indicated. So they come into your office in crisis, you want to be asking about suicidal ideation and homicidal ideation. You always want to do it at an intake evaluation. You always want to do it anytime there is a change in status or in treatment settings. So if they go from an IOP down to outpatient, we want to reassess, or vice versa. If they've been doing really, really poorly and all of a sudden they come in a super chipper attitude, we want to assess for risk, or vice versa, right? They've been doing fairly well and stable, and all of a sudden they come in, they haven't showered in 3 days, and they're tearful and they're crying. We want to be assessing. Anytime there's a major change in status, or change in status in terms of their world. So if they lose housing, if they get the diagnosis of a significant illness or a terminal illness, anytime something major has changed in their life, we want to do a risk assessment. Lack of improvement or worsening of symptoms, that sense of I'm a burden and feeling hopeless are really significant. So if we see somebody who's just continuing to get worse, we want to be assessing. If you anticipate any significant losses or major stressors, like I said, losing housing or getting a diagnosis that's really difficult to handle, somebody in their life dies, we want to assess. Those things are really important. So let's talk about what these factors are that you're going to be paying attention to. First is thinking in your head what's modifiable and what's not modifiable. And that means, can it be changed or can it not be changed? So factors that are not modifiable include things like family history, their personal past history, their demographics. So those risks that we talked about, being white over the age of 65, male, being Native American, under the age of 25. Those are different variables you can't change about the person. They're not modifiable. They are risk factors that will always be there. So we want to be considering that. What are modifiable risk factors? These are things that we can target for intervention. That's their psychiatric symptoms, their level of social support, and their access to lethal means. So those are things you can be a participant in helping to decrease the level of risk. And then we have modifiable protective factors. Again, things that you can be a participant in helping them to bolster or have more of. So thinking that sense of responsibility to family rather than I'm a burden. What is their reality testing ability? How many positive coping skills do they have, or problem solving skills do they have? How much social support do they have? And what is their perception in terms of the therapeutic relationship? How can they feel that even if no one else is in their life, they're connected to you and you care about them and you're invested in them? They are not a burden to you, right? So those are all things, these modifiable risk factors and protective factors, things we can do. Did you want to say something?
No,
okay,
not yet.
Okay. So we talked about these factors. Now, what are warning signs? Because these are not the same thing. Warning signs are person-specific emotions, thoughts, or behaviors that may come before you see an attempt. So if we think about, this is the stuff that happens in really close time to the suicidal behavior and should be like that big red warrant like flag that pops into your brain that means imminent risk, right? Something is going to happen soon. So when you're seeing this sort of stuff, we absolutely want to trigger a complete risk assessment and a crisis plan. We want to make sure that a crisis plan is there and available for the patient so that they have that to work from. So this is a way of looking at it as a comparison. So this is some of the risk factors, right? Both modifiable and not modifiable. And then when you look at the warning signs, you can see that these are the behaviors that might be showing up as a response to those risk factors. So threatening or talking about or wanting to commit suicide, looking for those lethal means, buying a gun, buying rope, stockpiling their pills, talking about or writing about death or dying, increasing their use of substances. We see a lot of time with our opiate using population, they start, their plan starts to become, well, I'm just going to overdose. I'm just going to double or triple the amount of heroin that I've been using. So if you're starting to see that when you're asking about their use, that's a warning sign. Stating no reason for living, feeling trapped, having a lot more of these symptoms, anxiety, agitation, particularly insomnia. Insomnia is one we want to pay very close attention to, and that should be a big red warning sign for you when you see people stop sleeping. Because even when we go a couple hours less sleep than what we need to get, our ability to stay rational and to think, to use our critical thinking skills breaks down significantly. So when somebody starts to have less and less sleep or go for several days without sleeping, their ability to abstain from acting impulsively is really going to be non-existent. So the insomnia is a huge warning sign. Feeling hopelessness or helpless, feeling withdrawn and isolated, and like their sense of burden. Okay, so I told you I would talk more about firearms. I cannot emphasize enough how important this is. Firearms account for 55 to 60% of all completed suicides. It is a huge risk. Firearms being in the home are a risk for adolescents no matter what else is on the table. So if you have somebody under the age of 18 and you don't know if there's guns in the house, you need to be asking. And I ask about guns in the house with every single person that I work with because I don't know if there's children or adolescents in the home. And I want to protect them as much as I want to protect the adult that I might be working with or the parent that I might be working with. Why is this such a risk? Because we already said adolescents act impulsively. And if they're having a bad day and they're feeling overly emotional and they can get their hands on a gun, that's a real problem. They are twice as likely to be found in the homes of suicide victims than in those who have attempted. So we know this is one of the reasons why it's so important, because it is such a lethal means. It also doesn't matter what type of gun it is. So if they're like, oh, it's a rifle, I only use it for hunting. It doesn't matter. We still need to know about it, and we want to problem solve with them how to store it and lock it correctly. So risk management always includes asking about firearms, who has access, where does it live? Can they get a gun locker or a gun safe to keep it in? Can they get a gun lock? And if they're having active suicidal ideation, can you work with them to help them problem solve? Who else can hold on to that gun for them until that suicidal ideation comes off the table? Can they change the lock on the safe so they don't have access for a period of time? That this can be a really active and empowering conversation to have with the person, because what you're communicating is, I care about you and I want you to stay alive. And I recognize that as long as you have access to this in the home and you're feeling suicidal, this is a big time risk. So keeping in mind, that's a very important variable with doing adequate risk assessment. The other thing to think about is that we know that people can have suicidal ideation for different reasons, like we talked about, but also at different levels of chronicity, right? So we know that how I'm going to approach somebody who becomes acutely suicidal, meaning that it's high intensity, high frequency of the ideation. They start to have a plan. They start to have intent to act on it. I'm going to need to take a different course of action than I might with somebody who sort of chronically for years on end has sort of that, I would be better off dead sitting in the back of their head, but no real plan, no real intent. It's just something that stays on the table for them as a backup plan. And it's been there for years and years and years, right? So thinking about these are two different types of suicidal ideation, and we might have to have two different responses to deal with them. That we don't want to take somebody who is chronically low-level suicidal ideation and send them to the hospital every time they tell me that they're having a thought about suicide, because it's never going to go away, right? And we're not going to be able to lock them up until it goes away. We want to help them problem solve and give them more coping skills to manage that thought. That's different for somebody who comes in and is acutely suicidal and they have a plan and they intend to act on it. Those are the people we want to be sending to the hospital for a short period of time to help bring down that level of acuity. So thinking that we might have to have a different plan depending on the chronicity of the ideation. This is a list of structured risk assessments. Not all of these are public domain. All of these you do need an independent license to be able to give. Except for the Columbia screen. The Columbia Severity Rating Scale is public domain, and a peer support worker could administer the screening tool for that, but then you would want to pass that person along to a licensed clinician to be able to complete the whole rating scale, because it's a clinical interview. But these are some tools that if you're not familiar with and you would like a structured interview to help you with your risk assessment process, please feel free to look them up. They're all valid and reliable tools. I'm going to give you a simplified risk assessment process just for the purpose of this lecture, to sort of think about applying in general to the majority of the people that you see. So thinking there are 5 risk factors to keep an eye on, 5 warning signs, and then 5 steps to take. So the 5 warning signs that we want to be keeping in mind: suicidal or homicidal ideation. So that's the rumination, any kind of planning, preparing, any kind of access that might be going on, access to lethal means. A sudden change in mood with no known reason. Anxiety, agitation, insomnia, despair, and helplessness. If these things are on board, those are big warning signs we want to pay attention to. That sense of burdensomeness, so feeling like a burden to others. And then having a poor treatment alliance. So there are multiple warning signs to keep in mind, but what this is suggesting is that these 5 are kind of the big ones that we want to, if we see these, then that's a problem. We want to really slow down and pay attention. Again, many risk factors to consider, but these are the 5 that kind of take priority. Previous attempts or exposure to violent self-injury or self-aggression. So sort of any of that cutting or hurting of themselves, and a previous attempt are big risk factors. Previous attempts are probably our most predictive risk factor for subsequent attempts. Having a diagnosed mental illness, particularly depression, and substance use. So when those 2 things are on the table. Having social isolation or a recent loss. Having a family history or exposure to suicide, particularly if it was a parent or a guardian that completed suicide, that's a big risk factor. And then being Native American or white of the male gender. That those 5 things are the biggest risk factors that we want to be prioritizing. So what are the steps that we want to be taking when doing a risk assessment? Well, the first thing is we want to be looking at the risk factor and the warning sign. Has the client made previous suicide attempts, shown self-interest behavior or violence? Are they showing the intention to act on it, or are they telling you the intention to act on it? Don't be afraid to ask directly. Stay calm and be non-judgmental, but always ask. And you want to use the correct language. You don't want to say, are you thinking about hurting yourself? You want to say, are you thinking about killing yourself? Because those are 2 different things. So don't be afraid to be clear, direct, calm, and non-judgmental, but ask the question. Are you thinking about killing yourself? Have you attempted to kill yourself in the past? Ask about their mental state. So you're asking about what is their level of reality testing? Are they oriented? What are the symptoms that they're experiencing? How many substances are they using? And then what's going on with those different symptoms? How much are you sleeping right now? How much did you sleep last night? What's your sense that with your mood on a scale of 1 to 10? What would you rate your mood at, right? And then if you're noticing a sudden increase in their substances. You also want to ask about their social connectedness and stressors. How isolated are they? How much stress are they experiencing? What is their perception of those losses, whether that's job loss, housing loss, income, loved ones, and then what is their exposure, a previous exposure to suicide or violence? And then do they feel like a sense of that they're a burden or that they're really disconnected from their social group? Then you want to assess for treatment alliance, right? So if there's no treatment alliance, they don't feel like they're connected to you. They're not communicating with you. Do they feel like anyone in this organization could help them? Have they worked with someone that's helped them in the past? Can you get them to that person today to have a conversation, right? We want to be assessing for how aligned are they with the service that you're providing. And then in terms of the warning signs, are they showing sudden, unexplained improvement out of nowhere? Maybe they've done a lot of things and that improvement makes sense, but let's figure that out. Let's ask those questions. Or are they starting to tell caregivers or the loved ones in their life basically oh yeah, everything's fine, but you have all these other risk factors on the table, right? So that what the person that's sitting in front of us looks like they're in that premeditation phase. They're starting to actually plan for acting on it. And then number 5 is let's ask about what is the plan for reducing risk. The basic plan should include reducing those 5 risk factors and enhancing as many protective factors as we possibly can. Knowing safety supersedes everything. It doesn't matter where you are in the course of your treatment with that person. It doesn't matter what you plan to do that day. If you see those risk factors and warning signs show up and you need to do a risk assessment and a crisis plan, that becomes the priority. That is what you do. If you need to send them to the hospital and you're worried they're going to hate me, they're not going to come back, they're going to hate this clinic, that is what you do. You want to keep them alive for that day. That is the most important thing. If they call you and say, I'm just going to kill myself, and they hang up the phone and you're worried, if I call the police or if I do a wellness check, they're never going to come back and talk to me, that cannot be the number one priority. The number one priority has to always be to keep them alive in that moment. If you ever have a doubt, please ask for a consult. I never do a wellness check. I never send somebody to the hospital without having a colleague do a secondary evaluation. That is always good practice. So please have multiple people sit with that person.
And just to add here, in my practice, what I've learned is that people, once they're on the other side of it and they're still alive and out of the hospital, they're grateful.
Yes.
They say, I've had people say to me, thank you so much. I was really mad when you wanted me to go to the hospital at first, but now, it's the best thing that could have happened.
Exactly. So. Thank you for saying that. That's totally correct. I want to just spend 2 minutes and breeze through homicidal risk assessment, because I don't think we give this enough attention. And then we'll talk about crisis planning briefly, and then leave some time at the end for questions. So other directed violent behavior or ideation, this, just for those of you that might not be aware, TerraSoft versus Regents of UC, this was a court case that said that had to do with a woman who was killed because a patient had told the therapist that he was gonna kill, I believe it was his girlfriend or his ex-wife, and that professional did not inform law enforcement, did not inform the intended victim, and then she was murdered. And so the family sued, and now we've since this case identified that there is a duty to protect the intended victim. So again, safety supersedes everything. So when we hear somebody who has homicidal ideation, a plan, and an intended victim, we have to take specific steps. If you are a licensed professional, you are mandated to do that in the state of New Mexico. New Mexico is a duty to warn state. So that means that when we hear that kind of information, we need to follow through on some specific things. We will need to contact law enforcement and or contact the intended victim to make sure that they can stay safe, as well as follow through on a plan for the patient that's sitting in front of us. And sometimes that does mean hospitalization. That doesn't mean you act on it when they say things like, oh, I'm so mad at my mom, I wish I could kill her, right? I mean, that's where we have to use our clinical judgment to assess further. Is that just a thought that they're having, which is a relatively normal thought to have, or do they have a legitimate plan and intention to act on that plan? Those are two very different things. When you're doing homicidal risk assessment, some factors to consider is your personal safety. You cannot do an adequate risk assessment with somebody if you do not feel safe with them in the room. So if you feel unsafe, get out of there. That's time to call security and wait until another time of which they can be assessed more thoroughly. You also want to evaluate their situation and their perceptions of it. Just like we do a suicidal risk, what are the risks and the protective factors? A lot of them are the same. So asking them questions like, is there really no other alternative to this? Is there no other way to handle this situation? What is their access to that person? We also want to assess for a detailed history of past acts of violence, just like past suicide attempts are the most predictive risk factor for subsequent attempts. Past physical aggression, so beating up, hitting, hurting people with weapons, making attempts on other people's lives, though that is the biggest, most predictive variable for future acts of violence. If they have absolutely no aggressive or violence history, then it probably is just in the land of ideation, and we can assess really thoroughly and try to get more information. This is why collateral is so important. If you do not routinely talk to family members as part of your intake process, you might only be getting one piece of the puzzle. You might not know that person's aggression history. So that's an important thing to add into your intake process if you haven't already. You also want to assess for psychopathology, so the person's level of reality testing. Are they having any command hallucinations or delusions? Their level of paranoia, their level of substance abuse. Do they have a diagnosis of antisocial personality disorder? These are the types of things that tend to be more predictive of homicidal risk. And then we also want to consider suicidal risk, because we know that it is fairly common to see somebody commit homicide and then kill themselves afterwards. So they themselves become at greater risk if they're in the process of thinking how they're going to kill somebody else. So we want to be assessing for both of those at the same time. So now what? You've assessed, you've determined the level of risk. What do you do now? What is the plan? So the steps to follow: first, we want to complete a thorough risk assessment. If the risk is determined to be low, then you can just provide them information on emergency services. I give the crisis line and the 1-800-273-TALK, which is the national suicide hotline, to everybody. It's just like, have this in case you need it. If their level of risk is assessed as moderate, that requires an additional step of completing a safety plan or updating their existing safety plan, printing it or doing it hard copy and giving it to them to take home, talking with them about where it's going to live. That's really important. And maybe also including significant others in that process, so that significant others, hey, FYI, these warning signs are coming up. Their risk is a little more intense. We need to increase the social support, decrease that sense of being a burden to their family. How can we get those people in the room to have the conversation too? If the level of risk is assessed at high for either homicidal or suicidal stuff, that's when we want to get them to the ER. That's when we call an ambulance, or we get them over to an emergency facility where they can be reassessed and maybe even hospitalized. This is a decision tree just to help with some of that clinical decision making. Again, I want to emphasize there is no 100% infallible way of doing this. This really is a clinical judgment. So thinking about some of these variables and how they stack up, I wanted to provide you with this decision tree to sort of think about. So feel free to refer back to this because it might be helpful in some of your thinking and what is the next step based on the level of risk that you assess. So crisis and safety planning, what is it? There's a history of these suicide contracts. I'm gonna have the person sign a piece of paper that says they're not gonna kill themselves between now and the next time they see me. There's no data that supports that this is effective. Please don't use them. If you were trained to use them, that is outdated information. Actually, what we know that this does is it just makes the therapist feel better. That's all that this does, and it puts you in a really weird dynamic with the patient. So don't use a no suicide contract to ask them to promise that they're going to stay alive. That is not a best way of doing it. What you should do, however, is make sure that all of your patients have a crisis and safety plan. This should be a collaborative experience with the patient. It should be a paper form that they get to take home. We use an electronic medical record, so we also have it stored in the electronic medical record, but our patients have a hard copy that they keep with them. This allows them to write it in their own words and to really collaborate with you in building it. Instructions should be very brief and straightforward. We want them to be very easy to read and really at a 3rd to 5th grade reading level. We want to address any barriers to using the plan. So it's one thing to collaborate in creating the plan, and then the next step is to say, how are you going to use it? Where's it going to live? You can put it on your fridge. You're going to keep a copy in your car. You're going to keep a copy in your wallet. I'm going to shrink it down and put it on a note card so that you always have it. You always want to have the names and numbers of any of the people in their life that are emergency contacts. That suicide hotline, maybe your number, their multiple loved ones' numbers. The reason why is these people can get into a state, they can lose their phone, they can lose access. We want them to be able to borrow a phone, go to a pay phone, but always have the number on them. So that's important. How do we implement it? Assess how likely they are to use the safety plan, problem solve around any barriers. What's going to get in the way of you acting on this plan, being able to use this plan? Where are they going to keep it? Have multiple copies and multiple versions available. Review and update it frequently. Every time you do a risk assessment, you need to update their safety plan because things change. And decide with them whom and how, who they're going to share the plan with and how they're going to share the plan with them. Even if you have to bring the family in to talk with the family so that they're not scared, right? Discuss the location of where it lives and discuss how it should be used during a crisis. Some take-homes that I want people to remember, because I know this can be very, very scary, is most people do not want to end their lives. Like you shared, most people are actually quite relieved when we help them with this type of stuff. They want a way to end the psychological pain and suffering. So if we can provide that hope and say, look, this is stuff that can be treated. This is stuff that we can help you with. If you can hang on, there is a plan. Death doesn't have to be the only way out. We also want to tell them that when they're thinking about suicide, that's an understandable option for coping with pain. It doesn't need to be the option that they take, though. So often just asking them will give them an opportunity to share those thoughts and begin to brainstorm alternatives. If we never ask, that opportunity doesn't present and we've missed something really important. Also understand that most people have psychological problems, social problems, limited coping skills, and these are all things that you as a mental health professional are trained to tackle or can get training to tackle. So these are not problems that we cannot handle as mental health professionals. Okay, so that's my spiel. Did you have anything to add?
So I think this is a great presentation, and I wish I had access to it when I was doing more clinical work. But so one of the things that occurred to me when you said that there are more suicides in the spring, I worked a lot with adolescents. That's been most of my career. And what I noticed, and this is purely anecdotal, and I don't know if any of you have the same experience, but that teens often attempted in the spring due to school and grades, the pressure, because that was when they were getting their grades at the end of the year and a determination of whether they were going to graduate. So seniors, you know, they were really, it's like a milestone in terms of school. So that was just interesting to me, and I wondered if that was ever addressed or has ever been addressed.
That correlation?
Yeah.
You should look it up. I don't know.
Should. So anyway, that was just interesting to me. And then asking the question clearly, asking, you know, do you plan to kill yourself, or have you thought about killing yourself? And using the word killing yourself, especially with adolescents and kids and also developmentally delayed adults, is so important, because hurting yourself is not the same question. So that was, I really like the way.
Right. So always asking about the thoughts. Are you having any thoughts about killing yourself? If the answer is yes, do you have a plan? If the answer is yes, what is the plan? Tell me specifically. And then asking about intent. What is the likelihood you're going to act on this plan? When is your time frame for acting on this plan? Being very, very clear in the questions.
Right.
Excellent.
And then I talked about that many times people are grateful. And then also one of the things that you talked about with homicidal risk, this reminded me of this kid that I saw in high school a couple of years ago, who there was this fear of somebody, there were threats of some other kid shooting up the school. Well, we were worried that it was this particular kid on my caseload. And what I did was I reached out with the family's permission to talk to another therapist who I knew had worked with him in the past. And that was so helpful, because it turned out that he had really never had any history of harm to others in the past. And so I think that's a great step.
Yes, exactly.
So.
And just want you to know, in addition to the slides, you guys are going to be getting a one-page handout that breaks down those 5 warning signs, risk factors, and then the 5 steps. So you can have that that we talked about today to refer to, if that's helpful. And just reiterate again, you never ever do this alone, that you always want to consult with a colleague or somebody else that can look at them. And for those of you that are peer support workers, if you recognize those risk factors or those warning signs with the person sitting in front of you, please get them to a licensed professional to be evaluated. Know that you play such an important role in helping us to catch things early. So if you don't, it is not the expectation that you do the risk assessment or ask those questions. It is the expectation that if you see those risk factors, that you get them to the right person who can ask those questions. So who has questions for us?
So Christina just said we recently started using the safety protocol with CSSRS here at HMS. The form is easy to read and uses coloring systems so that it's easy to follow.
Awesome. Great. Yeah, I've heard good things about that.
Anybody else have any cases or anything that struck them about the presentation?
Hey, this is Delia. I also had someone that I did a safety test for, and at the time I was like, I don't know, I was a little fearful, and then afterwards he was so mad. Like when I talked to his mom afterwards, he was so mad, but I ended up closing this case because he wouldn't answer my calls after I would call him several times, but he still reaches out to me when he does need help, like scheduling with a doctor, or if he needs help finding a provider. So, and I know he's sober in these services, so I'm really, that was a good call, and, not to be afraid of calling the police and stuff. I think that's always a good outcome.
So we had a little difficulty hearing you. I think did you hear what she said?
I think you said that, this could be wrong, but I think you said that you had someone who was initially upset about reporting a suicide, but then was grateful.
Yeah, that's kind of the point. Yeah, at first, he was a little angry with me, and when I called his mom to follow up, he was yelling me and stuff. But at the end, I know he's sober now, receiving services, and he still calls me when he needs a provider or needs to schedule an appointment with someone. So I know it was a good decision in the end.
Oh, good.
Yeah,
so
it was the right call.
Yeah.
Absolutely, the right call. Thank you. Thank you for sharing that. Anybody else? Okay, well, just an FYI, today was longer than what we're planning to do. So the next time we're going to do a shorter lecture and have more time for discussion and case presentation.
Yeah.
So are you going to be following up?
Yes.
Okay.
Well, I have to talk a little bit more to people at CBH, but if any of you, I don't know if my email address is anywhere on here, I guess we can put it somewhere, but if any of you want to present a case for a future presentation, feel free to reach out to Kim for this time, and then we'll figure out how to get my email out there for next time, if that makes sense.
Perfect.
Hi guys, my name is Abe. I just wanted to say thank you for this presentation. And I was, I had a member referred to me who has attempted 3 times, and he lives with bipolar 2. So, you know, his ups and downs are, you know, 1 minute, it's very confusing to me. So it was very helpful to hear some of that information, you know, like one day he came in and he was just like, yeah, I'm going to start a business and I want to do this and I want to do, you know, and I got really nervous about, you know, about his change in you know, the change. And I started asking, him, you know, because he said also, you know, I'm trying to get rid of my bike, and I'm trying to get rid of this, and I'm trying to get rid of that, right? And these were all concerns, and I you know, reached out to some professional help. But it, you know, and it turned out that he was grateful that I did, you know, but, you know, I was wrong, and I'm glad I was wrong, but, you know, he was hurting financially, you know, but it's been quite the experience, because since I've been working with him, he's had 2 attempts, and I've been working with him for about 4 months now. And over the holiday, I was just so worried, you know, about it. Like, he was on my mind a lot. And when I saw him again, and I asked him how the holidays went and everything, he said fine. He's attempted suicide the 2 last times. The belt broke, and so he was unable to hang himself, and he was in a car and in a garage and tried to do it that way, and it didn't work. And he just realized that he made like a little promise to himself that you know, he could get through things, and obviously it's not meant to be, or whatever. That's what he was telling me, you know. But I'm curious, like, should I take that for what it is, or is that just, might that be something that he just might be telling me to kind of get me off his back a little bit about it, or?
Well, is he working with a licensed mental health counselor, or?
Yes.
Yes. Okay.
Yes.
And do you coordinate with that person? Do you communicate with that person?
I actually do not. I
Okay,
do not.
I would
That's
recommend.
through a hospital. Go ahead.
No, I said I would recommend that you try to get a release, so that when your gut is telling you something isn't quite right here, you can get him over to be evaluated very quickly, or let that provider know, because you're getting one piece of the picture, and
Right.
he might not be giving that same information to the person that he's working with, and it sounds like he's at significant risk. So you made absolutely the right call by getting him evaluated, and I'm glad you were wrong at that moment in time. But it's always better to err on the side of safety than to. So if you're doubting or you're worrying about it at all, you need to get a licensed provider in the room to help you sort through that.
And one of the things, Abe, that I've learned through practicing is that you weren't wrong in that hour, or in that 20 minutes or 30 minutes that he was suicidal.
That's right.
Suicidal thoughts and feelings tend to change very quickly. And they're very real when they occur.
When they're happening.
And when they're happening. And so I wouldn't even say the word wrong.
That's a good point.
You know what I mean?
It's a really good point.
Okay,
Yeah.
thank you.
It's the right call, absolutely. It is always the right call to ask the questions and reassess. And unfortunately, with bipolar disorder, it is a serious risk, and so you want to do ongoing assessment and try to coordinate. I would get a release and talk to his therapist regularly.
Right. Okay, I've requested it, and we've talked a little bit about it, but he was not quite trusting to that extent yet. So, but that was also like before the holidays, so maybe, you know, we'll revisit that conversation. I meet with him every week. Excited to meet with me every week. So yeah.
So you can frame it from the perspective that this is you helping him, right? That you guys working together as a team is going to allow you and the therapist to be better providers for him, to be a better support team for him. And say, you know, I'm worried about you. Be very real. Mm-hmm. It's okay to say that. I'm worried about the stuff you're telling me, and I wanna help you more than what I'm doing now, and I can't do that if I can't talk to your therapist.
Right. And you maybe have already done this, Abe, but I'm wondering, you know, if you just ask him, what are your fears about doing this release? And because even just getting it on the table, because he may have some little fear that you can help him let go of.
Yeah, perfect.
Yeah, that's good. Thank you.
Okay, well, I know we're over time, so thanks everybody for showing up today and being here for this lecture and participating. Very important topic. We hope to see you all next go around. When is the next? The 24th. January 24th. Same time, same place.
Thanks,
Okay.
everybody.
All right, take care.
Thank you.
Thank you for all the work you do. Can I just end the meeting?